Hi, my name is Brad. Today we'll talk about burns, specifically high temperature burns to the skin, excluding eyes, genitals and the respiratory tract. Later I'll be talking about the pathophysiology.
I'm Simon and I'll be talking about the patient presentation and epidemiology.
Hi, I'm Lachlan and I'll be talking about the treatment and the recovery processes.
Burns are an important topic for paramedics to understand, as even though they are around 1% of hospital admissions in Australia, they can be life-changing and good early intervention can help their recovery outlook. On to the pathophysiology. Burns are caused by exposing tissue to temperatures that exceed 40 degrees Celsius. These temperatures cause the proteins in the flesh to denature, causing tissue damage. This process occurs rapidly when temperatures exceed 60 degrees, and with even higher temperatures, the skin tissue combusts, causing irreversible damage to nerves, blood vessels, and all layers of the skin. Because of the insulating and protective property of skin, thermal burns rarely go deeper than the subcutaneous layer beneath the dermis. Burns are classified by how much tissue they have damaged and the depth of that damage. These fall into the categories of partial or full thickness and superficial or deep wounds. A superficial burn is known as a first-degree burn and doesn't cause cell death but causes redness, pain, and minimal edema at the site. Second-degree or partial thickness burns and are usually surrounded by first-degree. In these burns, the proteins in skin cells are damaged and the skin surface will show this by edema below the skin, causing blistering, pain, and a mottled colour ranging from red to white. Third-degree burns are where the full thickness of the skin is burnt. These appear as dry and can be black, brown, or waxy white. These are usually accompanied by a burning smell and a lack of sensation as the nerves have been damaged. Though fourth and fifth categories exist for muscle and bone respectively, they are not commonly used, so will not be covered in detail here. Areas of damage caused by a burn can be classified into three parts. Zone 1 is coagulation, where the tissues are dead and there is irreversible damage. Zone 2, stasis, is adjacent to Zone 1 and has moderate damage with increased cell permeability and vasoconstriction, along with local inflammatory reactions causing ischemia. If these areas are not treated appropriately, they can progress to Zone 1 and become non-recoverable. Zone 3 tissues are last and are influenced by the inflammatory mediators released by the other zones. They have increased blood flow but are not in danger of deterioration or loss. Increasing damage to the body's cells, whether through more serious burns or a greater surface area, has larger influence on the rest of the body. Due to the break in the body's first-line defensive mechanism, it opens up for infection. The warm and moist conditions that a body uses to repair the wound are perfect for microbial growth. This increases the immune response at the site of injury and potential for infection or more serious conditions like sepsis. When these damages take place, many processes are put into action, including increased release of antigens and stress hormones and increased immune activity. These cause significant loss of protein-rich fluid into the interstitium, lowering blood flow, cardiac output, tissue oxygenation, waste removal, and nutrient supply to tissues. This movement of fluid causes edema around the burn. The reduced blood flow can cause issues for many organs, particularly the kidneys, where a reduced but more concentrated blood causes glomerular filtration rate to drop, with the potential to cause renal toxicity. The second and longest stage of burns is a hypermetabolic state. This is created by the increase in stress hormones and energy requirements of tissue repair. This load increases with the depth and size of burnt areas, with deep burns of large surface area taking around 1 year to return to a base metabolic rate.
Moving on to epidemiology and patient presentation. As Brad mentioned before, 1% of all hospitalizations were attributed to burns, and in 2013-14 there were 5,430 cases. 2/3 of burns patients were male, with the highest rate of burns injury in the youngest age group of 0 to 4 for both girls and boys. Aboriginal and Torres Strait Islanders made up 9% of all burns cases. Most burns were partial thickness at 70%, full thickness at 23%, and superficial at 7%. 21% of all burns were hand or wrist related, and in very young children, 21% of burns were to the trunk, where those aged 65 years and over, 22% of burns were to the hips and lower limbs. The average length of stay for all burns cases was 7 days. In 65 years and over, it was 13 days. 48 burn victims died in hospital. 27 of those were from full thickness burns to more than 50% of the total body surface area. There were 3 main causes of burns in this report. They were exposure to smoke, fire and flames, which made up 29%. Other external causes of burns such as explosions and contact with electrical transmission lines made up 26%, and contact with heat and hot substances made up 45%. This includes spilling hot drinks, foods, cooking and touching hot surfaces and appliances. Patients with thermal burns would normally present in this way. Thermal burn injuries can be divided into primary injuries and secondary injuries. Primary injuries lead to immediate and visible damage, whereas second injuries lead to morbidity. Initially, the patient may present with redness, swelling, blistering, or altered sensation where the surrounding areas will become hypersensitive. These may eventually lead to hypovolemic shock, hypothermia, infection, deranged blood results, and other metabolic changes. Hypovolemic shock can occur in patients with burns of greater than 25% total body surface area. This is caused by increased vascular permeability and happens in the first 36 hours. Protein leaks out into the interstitial spaces, taking fluids with them. This is in addition to the fluid already lost from the burns area, causing edema and dehydration. Metabolic changes can occur 48 hours after the burn injury, such as increased cardiac output and temperature, which is the body's systemic inflammatory response. Compartment syndrome can also occur if there are burns in certain areas. Swelling causes blood vessels and nerves to become constricted, and this can lead to muscle and tissue damage. If this occurs in areas around the major organs such as the abdomen and chest, this can lead to cardiac and pulmonary complications, renal impairment, and gut ischemia. Additional injuries can also occur from plain burns such as airway and breathing problems, but these relate more to chemical burns and smoke inhalation. The capacity for a patient to heal on their own will largely depend on the depth of the burn. Superficial burns exposed after removal of blisters are very moist and pink with quick capillary refill and will heal quite quickly within 7 days. Deep burns will have slow capillary refill and are harder to predict their healing times, but normally within 21 days. There are also modifying factors that will affect a patient's healing. Wounds that are initially superficial can become deeper and fail to heal due to infection, and burns involving feet and legs can become more swollen in the days after an injury if a patient does not rest with their limbs elevated. Elderly and unwell patients are the most vulnerable to burns as they often have limited capacity to heal, even for superficial burns.
Thanks, Brad. Thanks, Simon. Alright, so accurate assessment and management of burns is essential to ensure the best possible outcome for patients. 9 important steps in achieving this include stopping the burning process, cooling the burning wound, dressing appropriately, a safe approach, managing imminently life-threatening problems, cannulation for IV fluids, assessment of burn severity, analgesia, and lastly transport. AV utilises the Wallace Rule of 9 to estimate the TBSA or total burn surface area where each body part is expressed as a percentage. So the chest and abdo will be 18%, each arm 9%, the legs 18% and the back 18% also. Pre-hospital management of thermal burns include cooling the burning wound with cool, clean, gentle running water for at least 20 minutes. Though consideration of hypothermia must be made for patients with large burns, and in these cases transport should not be delayed. Water gel dressings may be considered where no other form of cooling is available. The 20-minute cooling time includes any cooling performed prior to paramedic arrival. Ultimately, you will need to cool the burn and warm the patient. Paramedics should provide pain relief as burns can be particularly painful with little relief for long periods of time. Once a burn has been cooled, it needs dressing. For burns that have not broken the skin, a moist gauze may help with the pain. So Brad will demonstrate how that is done. So he's got some normal saline, which he's going to dress, and he's going to put it on the affected side. Like so. Beautiful. However, cling wrap is the preferred method for all serious burns and should be placed longitudinally. Like so, just over the affected side, and that will allow for the swelling. Lovely. Happy days. If burns exceed 15% TBSA, paramedics will provide IV fluid replacement. The required amount of fluid in millilitres is calculated by TBSA times the patient's weight. This will be administered over 2 hours from the time of injury. If the burn covers critical body areas such as the hands, face, genitals, or covers greater than 20% TBSA, they will require treatment by a specialised burn service. In Victoria, the Alfred is a preferred burns trauma hospital. Hospitals will need to be notified prior to the arrival for critical burns patients. Hospital care and rehabilitation seeks to minimise the amount of scarring that occurs to the skin and underlying tissue. However, the deeper the burn wound, the more scar tissue will form around the injured site. Hospital care procedures for partial or full thickness burn wounds may include escharotomy, debridement, and skin grafts. During the healing process, patients may complain of itching, pain, and discomfort during their hospital recovery phase. Treatment of this may include moisturisers, and non-steroidal anti-inflammatory drugs alongside analgesics.
I hope you guys have learned something about burns today, and from what happens at a cellular level, how the patients may present, and what we as paramedics can do to manage them. Although only about 1% of hospitalisations are related to burns injuries in Australia each year, it is an important part of paramedic practice as good early assessment and treatment will ensure better patient outcomes.